All right, guys, we're back. Part 2 of GYN series, and we're going to start talking about the assessment and management of the patient. Now, kind of split this one up into two because there's some specific things we're going to talk about in the second part of that. But we're going to talk about right now actually how we go about assessing a gynecological patient. And again, I think that one of the things that you got to absolutely make sure that when you have a woman of childbearing age, and I would say somewhere between 10 and 55, you've got to be looking at maybe this could be a gynecological problem, especially when we're dealing with abdominal pain, pelvic pain. Okay, so I think that it's usually due to the problem with the reproductive cycle. By the way. So again, your primary assessment, go to secondary assessment, kind of the basics, but you're going to need to ask specific questions. And I think you got to watch out on this one, especially number one, if you're dealing with a younger child, you really need to be involving in, by the way, yes, I have seen sexually active 13-year-olds. Okay. It's kind of scary actually. But yeah, it is possible, and it's a possibility that they could be pregnant. And, of course, that causes all kinds of social family problems there when that happens. By the way, you need to assess the patient's emotional state. Remember, guys, ladies and gentlemen, this is a patient that's going to be a hormone soup, okay? And because of that, I think that discretion is absolutely 100% needed. We don't, in the middle of Walmart, ask these people, hey, have you had your period last week? No, let's not do that. All right. So again, usually the two big ones that we get for gynecologic emergencies are abdominal pain and vaginal bleeding. And the abdominal pain can be diffuse, not just localized to the lower area. A lot of times it is, but it can go all across. So we need to keep that in the back of our minds. Your OPQ-RST mnemonic is absolutely huge. We need to ask every one of these questions. And we're probably going to be asking 2 to 3 clarification questions about this. Dysmenorrhea, severe discomfort during the menstrual period. It's again it hurts very much when they do this. Dyspareunia is painful sexual intercourse. And guys, it's not because you're great. All right. Again, determine the associated signs and symptoms. All right. So try to find out these two particular things when we're dealing with the gynecological patient. Some other things I think that is kind of important, and we'll probably talk about this, is what their cycle was like. When was their last cycle? Have the cycles been normal? What is their obstetric history? We need to know the difference between gravida and parida. Gravida is the number of time the woman has been pregnant, including this one time if she is pregnant right now, if she knows it. And then parida or parity is the number of deliveries. The third part of that, which a lot of people forget about, is the number of abortions. Understand that abortion is not, we went to the clinic and got our uterine lining scraped out. It is when the pregnancy is ended before 20 weeks of gestation, regardless of the cause. That's medically what we consider an abortion, okay? And again, obtain their gynecological history. When is their last menstrual period? Have they been normal? Have they been regular? Heavy flow, light flow, depending on that. Check for ectopic pregnancies, infections in the past. If they've had tubal ligations. Remember, if they've cut the tubes, there could be scar tissue, and believe it or not, every now and then one gets through there. And so, again, if it's not a complete tubal ligation, they can have an ectopic pregnancy and not even understand why. Again, little sperm gets through that one little tiny hole. Again, most of the time when they do the tubals, they usually cut a certain section of it out. However, they don't always do that, okay? Abortions, dilation and cutlerage. These are when they scrape the uterine lining on the inside to help with endometriosis or endometriitis. Usually endometriosis, they'll scrape this lining out to help relieve some of the symptoms. So you'll ask them if they've ever had a DNC procedure. If they've had any prior trauma to the reproductive tract, okay? Kind of important, especially when they've done something they shouldn't have been doing. Sexually active, again, if you have any pain or bleeding during or after sexual intercourse. I think that's very important. You need to make sure that there again, dyspareunia, sorry, I keep saying that the wrong way. But when you have that, again, what's causing the damage, what might be causing is the male actually causing a problem during the intercourse period. You need to make sure you get their last menstrual period and ask if it was normal, heavier, or lighter than usual. We kind of talked about this a little bit earlier. And are you on birth control? Because actually birth control was used to help maintain regularity of periods in certain women. So you have to understand that. Also, easy way to menstrual flow is the number of tampons that they used or the number of pads that they've gone through. Okay. I'm not a total expert in this, but having having a wife and 2 daughters, I can tell you, usually, 2 to 3 is kind of my understanding of what's normal. But again, if they're flowing more than that there's probably something wrong and we need to check on why that's happening. If you suspect pregnancy, start asking about that. Breast tenderness, bloating, urinary frequency, nausea and vomiting. If they've gone 6 months without a period, and I'm not saying that doesn't happen, because there are sometimes women will stress, other factors will cause them to go 2, 3, 4 months without having a period. That does happen sometimes, but be highly suspicious of it. Especially, again, you look down, you see the bulging stomach. You reach down, you feel on the stomach, and you're feeling something. You're feeling the top of the fundus. About the umbilical level. Yeah, you might have a bun in the oven. So again, they got to make sure about that. Make sure that, again, don't go poking and prodding, but we need to find out. Assume any missed or late pregnancies, the pregnancy might, even though they may deny it. Yes, it is possible that you could do that. Again, ask if they've been using any contraceptive, what forms, and the varying degrees of effectiveness. Yes, there are certain ones that work better than others. The only 100% true fire is abstinence. Okay. That other than that, they all still run a risk of the female getting pregnant. And be familiar with the various forms. Okay. The condoms, again, they have vaginal condoms. They have intrauterine devices, the birth control methods, their rhythm method, again, where you time out. Where they actually, I've known people that take their temperature, and it's usually because they're trying to get pregnant. The uterus actually gets a little bit warmer, and the body gets a little bit warmer when you're ovulating, and when you see that small temperature change, they know that it's time to go. Now, again, physical exam of these patients. Again, limit them in the field. Okay, we want to maintain dignity, maintain privacy. Ladies and gentlemen, there is, in a gynecological patient, there is very little, I can't say never, but you shouldn't be sticking your hand in a vagina, period. Okay? You shouldn't. Unless there is some really weird, goofy reason why, you shouldn't be doing it. Okay? And when you are doing it, you need to explain to everybody involved why this is going on. And I would probably say, again, have medical professionals around you, because, again, you're going into very dangerous ground there. All right. Again, your level of consciousness, these are all of our basic things. Again, if I'm seeing cyanosis or pallor, I'm thinking that the patient's lost so much blood that she's now in shock. Or worse yet, something's torn on the inside, guys, where she's bleeding internally and we can't see it. But again, we should see a lot of other signs. We should see that hard abdomen, warm abdomen, flushed appearance, okay? The flushed appearance probably indicates more of a febrile situation, which is usually due to the infection. They could be going septic at that point. Again, vital signs, get your vital signs. Perform the tilt test for any orthostatic changes. Again, the ladies actually compensate pretty good. They're used to losing a little bit of blood, but they can also, again, they're a little bit more susceptible to, the orthostatic hypotension. So again, have them do the lay down, sit up, stand up, if you need to make sure that, that we don't have some mild hypovolemia going on. Check for discharges. That means either blood or other material. Okay. So again, if you've got an infection going on in there, again, you can have the yellow or white discharge. But again, it is something that we do get called for. If they've used more than 2 sanitary pads per hour, that is significant bleeding, okay? So if they're soaking through pads, we need to find out, this is a little bit bigger than a menses. The color discharge, again, most of the time, menstrual blood is not bright red. It's usually a darker reddish color. It is not the bright red, and there shouldn't be too many, I've seen a little bit of clotting, but not much. But again, you don't ever do an internal vaginal exam in the field. Do not. I can name multiple paramedics that have been fired for doing just that. Again, make sure you listen for bowel sounds to see if they're absent or they're hyperactive. Usually if they're in a shock, they're not present. Gently palpate the abdomen if you find any masses or distension. One of the other things that happens is sometimes you get tumor growth within the uterus, especially in your older ladies. So again, if you're feeling any type of masses or guarding, there's any rebound tenderness. If they have any type of ovarian cyst problem, you're probably not going to get to touch it, because the second you touch it, they're going to come off the stretcher on you. Okay. Primarily, we do supportive care for gynecological emergencies. Pretty simple. Get their vitals, put them on oxygen, start an IV on them, start flowing, give them a little bit of analgesia. If it really boils down to it, that's pretty much all that we're going to do for these folks. And when we get into specific types, we'll talk about the different things that you're going to do to help them. Again, your IV fluid therapy and replacement is usually not indicated unless they're showing severe signs of shock. Then I would say, and again, even then, you're replacing salt water. What they really need, if they're in that much of a shock state, is probably blood. We use, if there's excessive bleeding, again, 1 large bore IV, again, administering normal saline is usually all that you need there. Don't try to pack dressings in the vagina, place over it. Discourage the use of tampons to absorb the blood. Again, that I think causes a little bit more problems than good. Again, just use a sanitary pad. Abdominal pad works just great, guys. Count and document the number of sanitary pads that you actually go through. And then last but not least is a position of comfort, and it's usually going to be on their left side with their knees bent, okay? And so that decreases tension on the peritoneum, so it gives it a little bit more room and allows it, again, it's more size, it takes the pressure off, okay? This is why it's probably going to be the most comfortable. But again, it can also be on the right side, so don't be afraid to turn them on the right side to do that as well, okay? But again, whatever position makes them comfortable, all right? Again, opioids, we can use those to mitigate and alleviate some of the severe symptoms. I know that, again, that's a little bit on the controversial side. I think it's kind of bad not to do. I think that when you've got somebody sitting there writhing in pain and you have the ability to help their pain, the surgeons lose their mind because they want to be able to assess the abdominal pain. But again, you're not the one sitting there writhing in pain. So, again, treat your patient appropriately. And again, psychological support, remember to keep calm, especially if they are attempting to get pregnant and they're thinking that this is some sort of miscarriage situation. But again, it's very scary, and they know that. All right, we're going to start on this one on the next slide, guys. So I'll see you on the next one.